remote care. He's the head of the CommiSur Lab, his own lab at McGill. He's also the director of the Jean-Martin Laberge Fellowship in Global Pediatric Surgery, a founding member of the Global Initiative for Children's Surgery, and a member of the Order of Canada. Dan has published over 200 scientific papers, several book chapters, supervises multiple master's and PhD students from Canada and across the world. His current areas of academic interest are patient-centered care, healthcare AI, technology-assisted healthcare communication and medical education, and promoting global surgical equity and excellence for children through research. And finally, last but not least, Dan currently holds the title of Martin Valliere's favorite doctor for research. Go ahead, Dan, for your talk, Generative AI researchers and clinicians friends.
Thank you very much. Thank you. You can hear me well, I hope. A pleasure to be here, and thanks for the introduction. Very nice, glamorous introduction. Really, the one thing that mattered the most was your last statement, Martin. It's a pleasure to work with you, and it is through you and I've come to know a little bit more about the areas in which everybody in this room is interested in. Obviously, none of my competencies really add very much to what everybody knows already in your field, except maybe, possibly, hopefully, a little bit about generative AI. And that's the topic of my talk today, from the perspective of researchers and clinicians, understanding, I hope I'm correct in this, that these are the sort of main groups that are represented at these rounds. In case you wondered who the smiling drunk person is on my slide, I tenderly call him Plexi from Perplexity AI. He's what I called for the past 2 years my crazy drunk friend. I have to say that he's become a really good friend, artificial intelligence, obviously, and he's actually a bit less crazy and less drunk these days. And I'll show you some of the evidence for that soon. So in terms of conflicts of interest, for years, I was desperately hoping that I'll have some conflict of interest. Finally, I do. We do have 2 small startups in technology and healthcare. One's called Children's Journey. The other one is Petit VR for trauma simulation, none of which really bring any money to speak of, but that's my conflict of interest. And in terms of what we're going to do today, briefly, hard to know to gauge everybody's knowledge in terms of generative AI, so I'll just cover quickly some of the basics for that, specifically in healthcare. The bulk of the talk will actually be my feeble attempt at reviewing some of the newer applications, specifically within generative AI for radiation oncology and medical physics, so that hopefully this will be relevant to all of you. And then I will spend a bit of time talking about our own projects as an example of what happens here. So why talk about generative AI? Well, because it's a hot topic, obviously. Besides being hot, it offers in especially in many of our specialties, including the one that I'm represented in this room, the opportunity to link various data domains like radiology and text data based data. It can help very much enhance clinical workflows, and it definitely accelerates a variety of research processes that we'll talk about. Ultimately, though, it's just a hot topic, so why not talk about it? And here it is hot. I mean, if you look at some of the sort of achievements for generative AI, in ChatGPT, of course, was gamed to the point where it can boast such percentages that don't really mean a lot, but still 97% diagnostic accuracy for common surgical conditions, a real productivity boost up to 40% in radiology. The 2025 event was basically adoption to up to 100% of using ambient AI for doctors to have their notes written. for clinical documentation especially in the US, uh, even coming to McGill. And then altogether, not just Gen AI, but all AI, yes, we're talking about a huge market share for $200 billion. So it is interesting. Now, large language models, right? That's the basis of generative AI. Basically, transformers. The big change from convoluted neural and CNNs and RNNs, neural networks, to transformers is the fact that they have embedded in them this attention mechanism, which means that you don't just embed or transform numbers sort of transform letters into numbers, which is relatively easy to do, and the neural networks did that. But you are attentive to where in the sentence every word, every letter is found. That's the attention. And on the left, I put the now famous paper, "Attention is All You Need." There's literally songs that have been written about, composed on this "Attention is All You Need." A paper from 2017 that described the importance of attention for these language models. On top of it, very important for transformers, they have these efficient parallel text processing. Otherwise, it would take forever to analyze even a single sentence. So that's why you have these huge windows now that we have for text, because we can parallel process the embeddings. But ultimately, in the terms of essential components, you've got this word to mathematical representation conversion, the embeddings. And then once they're embedded, you've got a basic standard neural network, which uses the very standard gradient descent model to try to get the best as its desired outcome. In this case, it's called universal because basically everything that gets put in the model tries to go through this, goes through this gradient descent model. Now, if we unpack the LLMs a little bit more, in terms of the various forms, for the longest time, it was text models that we focused on. Text models have these discrete tokens. As you know, token is sort of like a word, but not quite a word, sometimes less, sometimes more than one word. They're very good for syntax, for semantics, for meaning, and for modeling these long-range sequences, because they are the long ranges of sentences in a book, for example. You can take a whole book and put it through, right? The training signal in their case is the next token prediction, with very dense supervision, very intense supervision at each step, which is characteristic for these text models. And they can generalize beautifully, particularly in issues of compositionality. So in terms of text and the content of the text and reasoning, and even symbolic structures, as we know by now when we ask our ChatGPT something about life. Image models came sort of separately, unbeknownst to many people. If they're exactly the same thing, they're still large language models, but they work very different because, of course, they don't have tokens. They have high dimensional continuous fields. And because of that, what they excel in is the spatial arrangement, structure, and texture. The training signal in this case are the pixels. And the way that this is done, rather than supervising them for next token prediction, you've got this reconstruction or diffusion denoising. In other words, you take the picture of the cat, and then you know it's a cat, and then you see what it takes to transform that cat into a gray field, completely amorphous field. That's called the denoising. And then you keep that model training that was done that way so that you can recreate a cat or a dog should the prompt change to the dog. And that's how that works, at least simplistically. To a non-computer scientist, I should stress that big time in front of people like you, which I am not. And the generalization is very good for patterns, of course, for appearance, and is not as good for logic. Multimodal models came in the past couple of years. I think Gemini 3 is the best example of a model, and a GPT-5 was, I think, a little bit earlier, where they decided that actually, rather than trying to use one or the other, they should just train them together in that joint space where they are aligned. Basically, vision and language are aligned. They share embeddings in the generative latent space. These are obviously able to do more, and they do what they do today, which is image captioning, visual Q&As, text to image, image grounded reasoning, all that stuff, which I do in my workshop last night as I'm creating furniture. It takes my picture and puts a frame around it and tells me how to build that frame. The weakness of the multimodal model, it really is just that if you use a lot more of one modality than the other, of course, the non-dominant modality will have more hallucination because it will be less trained. And that sort of makes sense. Finally, you've got foundation models, which are really the sort of, I always believed it's the way that it's all going to go to, where you've got many models, any type of modalities, not just text and image, but they're trained on massive corpora, which can be very heterogeneous, but they're still within a certain area in general. So the idea would be there is such a thing as a medical foundational model, but typically, for example, you have in pathology, that's a perfect example, or radiology, you have a foundation model where you've just put so many x-rays or so many slides, digitized whole slides, that regardless of what slide you put or x-ray you put it on, you give it to the model, it will make your diagnosis and it will suggest treatment and all the good stuff. So that's how these foundation model works. And we're still waiting for them to sort of take on. In the meanwhile, the regular models, the multimodal, simple models, the text image have improved quite a bit in the meanwhile. And the problem in foundation models is that it's quite opaque in terms of how things are represented internally in terms of the embeddings. And you've got, obviously, whatever data set you have, all the data, the biases in the data set, of course, beautifully are transferred, or terribly are transferred to your results. And there's also the potential for emerging failures at scale, in these large models. So with all that in mind, where do we in general apply this to healthcare? And I wrote there NLP because, of course, NLP is the precursor to large language models. It's not really, it's not the same semantically, they're very different. NLP is the field of natural language processing, where now really the traditional BERT type transformers that were used earlier on with very little attention and no parallel processing and small size have been replaced by large language models instead. And I've never found out if BERT, for example, it's still considered a large language model, but it's a small large language model, if that exists. So where do we use them? We use them in many areas quite successfully. We use them a lot in mining the electronic health record or medical record, where based on that medical record, the LLM can provide decisional support. That's very big. It can code for doctors. It can predict risk. And this is where it's used massively by the industry in the States. Big models that are distributed across huge medical clinical systems like Kaiser Permanente, of course, use this, and they use models, predictive models, and it's whether you like it or not, it's there. It is also being used for physicians and other providers to just extract regular info, to retrieve information. It's my Google. That's what I use now. Actually, when I have a patient in front of me here today in the clinic, I don't Google, of course. I go straight into my Perplexity, and it gives me the answer because it's already, although it's not a medical LLM, it is general purpose, out of the box, large language models like Gemini 3, Claude, the most recent Claude, Perplexity, and so forth, OpenAI, can be used, are very precise already for medical information, and they can synthesize complex information for clinician researchers. We use AI a lot for conversational AI, for intelligent conversational AI. In other words, we put it into our chatbots. Chatbots existed before AI, but they're pretty dumb chatbots. Now, of course, there are smart chatbots which can lead a conversation and still do the job that they're supposed to do as clinical assistants or whatever other assistants they are. They can be used for patient engagement. We have about 3 actually startup apps which where we're trying to put conversational AI as part of the app, of course. We use them for biomedical literature mining. This is important for researchers. We can do several tasks, and I'll mention that a bit later, in systematic reviews, identify drug repurposing, therapeutic pathways, stuff like that. They're used in healthcare for surveillance, for example, public health surveillance, using social media, outbreak detection for that from the days of COVID, where they started using this stuff, and to identify health trends. Very conveniently, we can use LLMs for weekly supervised labeling so that we don't have to spend months labeling our x-rays or our text or whatever we need to label, because we can use instructions through LLMs so that labeling process is only weekly rather than densely supervised. We use them a lot increasingly, as I mentioned since last year, as medical scribes and for documentation. It really streamlines a lot of the administration, documentation, note-taking, all that stuff. And finally, for the researchers among us, definitely they're used increasingly to accelerate patient enrollment by analyzing the EMR, matching patients to trials, and there's now fully sort of for-profit apps which conduct all your research. You can do it all through that if you have the cash. So, but you say, yeah, but LLMs hallucinate. That's been the answer I got for the past 2 years, and it was absolutely a reality 2 years ago, and it's not that much anymore. The reality, and I think the way to approach this is that hallucination is not a bad thing necessarily. It is a feature of stochasticity. All LLMs, unlike machine learning models, which are deterministic, these are all stochastic. That means that every time you generate, it's going to be a plausible, diverse output, intentionally avoiding stereotyped outputs, so that your essay for the student that submits their essay written by AI doesn't look always the same way. And because of that, in fact, they beautifully complement deterministic AI, which is machine learning. It adds narratives to machine learning. It adds counterfactuals. It adds alternative explanations for different quantitative predictions. And because of that, increasingly, we look at these hybrid workflows. I'll mention some examples of that in the literature, which are where the LLMs are going for the edge cases, for documentation, for hypothesis generation. And when you have a lot of uncertainty, by creating multiple distributions of these outputs, it can aggregate this uncertainty across various fields, and they lead more consensus-driven suggestions. By the way, if you wonder what the 2 funny characters are on the left side, because I'm not in the room, I can't sort of ask you to guess, but the one on the left represents the bull, because that's a lot of the bullshit, that hallucination that generative AI used to provide and still provides to some extent a lot of BS, and that's the bull. And the one on the right is the snake, which is because on the other side, deterministic deep learning models in healthcare have been a lot of snake oil. There's a lot of snake oil, a lot of hype associated with that, and much less in terms of good results. And the two represent, by the way, a famous, excellent book that I recommend to everybody on this whole topic of AI, which is called AI Snake Oil by a group at MIT. So applications in general of LLMs, specifically LLMs in healthcare research, project ideation. I mentioned you can start your project because of stochasticity, generating hypotheses and refining them. When you get to the literature review, you can do your literature scan, of course. You can analyze the literature with that. You can summarize regarding language. Language is no longer a problem. And you can even do systematic reviews. One of our projects I'll show a bit later. One can do a lot for data analysis and visualization. I use it a lot. I review all my statistical outputs. I ask it to review it just in case it's wrong. I'm not that strong in stats. I can just give it any code, whether R or Python, or any code for that matter, which can, of course, it can review. And when it comes to nice charts and visualizations, it does a beautiful job at that. For our scientific writing, it will, of course, fine-tune my students' writing, makes my job so much easier, and it wordsmiths and finds just the right word for the right thing. It shortens the manuscripts and those abstracts that in 12 hours you have to reduce from 500 words to 300 words. It does a beautiful job at that, and it helps me quite a bit in the process of grant application assistance. It never replaces what my thinking is, but it helps a lot. It's also superb for lots of administrative tasks, like boring administrative tasks that we all have, various summaries for work, annual reports, letters, reference letters. I don't ever write a letter straight based on AI, but I put my own ideas and then it does the letter around it and around the CV. It can incorporate CV data, in fact, in these reference letters. It can generate a lot of documents that are needed in the format by research ethics boards, for example, and stuff like that. And when it comes to translation, knowledge translation, create beautiful slides, generate AI talks like this one. This talk was basically, I wrote it in Gamma, which uses AI to do it. It's all my content. I had to work on every slide and to work on every word in the slide so that I'm happy with it, but it at least created the pretty slides for me. It can generate illustrations. We know about that. Very good for patient-facing materials, multi-language versions, stuff like that. It's all good stuff. So let's talk a bit about Gen AI in radiation oncology and medical physics. Again, from a surgeon and researcher who knows very little about either, but has done some work to find out. And what you're going to see here is about 10 or so papers, recent papers, only 2024, 2025, in journals that I've trusted, like Nature, that showed me where basically your field is right now. I hope that some of these things will be sort of like, aha, good things for you, that you can know that at least it can be done. First of all, things such as clinical target volume delineation. LLMs can be used for that. The study here from Nature uses 3D CTV delineation, where it integrates not just the X-ray, but it integrates the stage, the surgery laterality, and the CT scan. And this is for breast and prostate radiotherapy. And when they've basically multimodal processing for all these nodes for CT volumes. They did voxel level segmentation and then compared to image alone. And basically what they got was outperformance, superior accuracy, generalization, data efficiency. And I'll show you this here. It's a little bit small, but that's the maximum size that I had here. But you can see the difference between, of course, you do it vision only AI, where you get these predictions, and then you do this multimodal AI where you've added charts and clinical data and stuff like that, and you get a different predicted one. And the for my simplistic mind, when you look at the DICE scores, you see that the multimodal one in green outperforms for internal sets of patients, external patients, two external sets of patients. And even I can tell without knowing anything about what this green is, but it's obviously radiotherapy areas. And I can see that the multimodal one is closer to the ground truth than the vision-only method. So that's nice, and that's useful here. And after after I finish talking, I'd love to hear from you if there's indeed, is this your experience? Are you using these things or not? Here's a similar one where you wanted to have full decision support for radiotherapy in neuro-onc, where they've evaluated GPT-4 with tumor board specialist recommendations and the European Society of Medical Oncology guidelines for RT on CNS tumors. And basically, they compare them, and what they find is that in general and this is three form, these are small, complex, simple, and complex, 3 levels of complexity cases. And for most of these, the GPT-4 this is all GPT-4 sensitivity, specificity, and the numbers are good. And depending on the case difficulty, you can see that you can get up to 100% specificity. It all hovers in the 80s and 90s. And when they compared the concordance between for Cohen's kappa and the concordance percent, you can see that it's pretty good, sort of 70s, 80s, 90s% concordance in this case. Cohen's kappa is for the internal consistency. So that's nice study, to the point where there's already applications of LLMs for these multidisciplinary tumor boards. This is from a recent paper. Show you what their poster looks like. Can I make it bigger? Yeah, I can. Can you see? Yeah, you can probably see it a little bit bigger. Yeah. So basically here, they've got 2 types of evaluations. One is with a draft system that just includes, uses the information from PubMed literature, and then an enhanced system where they use input literature as well, stuff like trials, drug approval, oncological guidelines, and so forth. And basically, they look at qualitative and quantitative analyses comparing to the tumor board itself. And what they find is that the treatment recommendations of these systems are pretty strong, pretty good compared to the experts. You can see that the disagreement rates with the actual human tumor board in the case of the enhanced system is 0 and 17 for the draft system. The concordance, again, is here in terms of cosine similarity. No, that's the one here. Cosine similarity in the 0.7% between the two. And again, the enhanced system is very concordant with the tumor board, which means that you can actually help a tumor board with AI in this fashion, which is pretty impressive. Then when it comes to radiotherapy planning, this is for intensity modulated RT using this LLM treatment planning system agent loop. This is 2025. It's an archive paper where they wanted to see if the LLM agent can interact autonomously with the treatment planning system to optimize the plans for head and neck cancer. Where in this case, because it's an agent, it actually does all the stuff. It reads the plan, including dose volume histograms, metrics, proposes new optimization objectives, submits the treatment planning system, iterates until the clinical criteria are met, and then it gets compared to physician plans on the symmetry and planning time. And what they found is that indeed they achieve comparable performance to clinical plans without any physicist intervention. Doesn't mean you're going to lose your jobs. Nobody needs to be afraid of that, but that's what it is, with significant acceleration of planning workflow. Even I could tell when I looked here, I don't really understand this, but I see that this is GPT and this is clinical. And yes, the treatment plan looked pretty similar between the two to my eye. So that is very positive. Obviously, this does not mean that it's starting to be used. It just shows feasibility. And of course, it needs to be validated prospectively, which all of this AI desperately needs to be validated prospectively. Similarly, here's a feasibility of automatic radiotherapy treatment planning, again, for cervical cancer. Here they generated, the question is whether they can generate volumetric modulated arc therapy, VMAT plans, comparable dosimetrically to human physicist plan, and specifically in terms of target conformity and organ at risk sparing. They had 35 cancer patients. 5 were used for training, 30 for testing. They used these models, pretty standard, regular models. And then they had these iteratively, they adjusted them for the best parameters. And they found indeed that these models, Llama models, for example, which are open source anyway, produce acceptable plans in about 10 minutes compared to 20 minutes by manual work, of course. And the conformity here was actually superior and very homogeneous and equivalent organ at risk dosing. And again, the pretty pictures, for me, they're very pretty pictures. And we see the different, you see the manual method, what it reached to, and for various cases, and you see what the plans were for Llama 2 and Quen. Llama 2 was, I think, a little bit stronger. Staying in a sort of a similar, but with a different type of an application, here we wanted to see if large language models can sort of improve the 3D dose prediction of a graph neural network, which is what they were using already for radiotherapy, but through a process of prompting. So they basically combine the LLMs with the GNN. Here's a classic example of sort of combining a deterministic with a stochastic model. And it accepts high-level instructions from the human in the loop to improve the GNN, the neural network, and to see how that will work. And in fact, this was shown to be positively. And I'll show you, the actual method is pretty clear, but here I'll just show you how this worked, which I thought I understood. Basically, you've got a first prediction by the GNN, not happy with it. The human prompts, prescription dose is too low in this case, increase it to 60 gray in 30 fractions, bang, improved. Low quality prediction again, prompt says the PTV shoulder is too soft, 195% of the PTV covered by 95% of the prescription dose, bang, it's done. It looked good. And at least this seemed to be good, and it got published in Medical Physics, so I imagine it is good. I think I just came out of my sorry, just one second. I'm just going to go back to the presentation mode. For some reason, it came out of that. There we go. We've seen this stuff. Yes, we've done this. And here we're going into a slightly different application for LLMs for CT simulation node summarization, where basically they use the LLM specifically to summarize the orders for simulation, for the simulation, the first scan, and for therapy, and they do that by summarizing, and they tried it across 7 disease modalities. They use 600 orders from the area database, locally hosted LLM for patient confidentiality, task-specific prompts, and a Java schema. A therapist is the one that verified the ground truth, and they assessed it at item level for accuracy. And what they found is that across all categories, 98% accuracy for this, which is nice. The larger model performed better than the smaller model. And they showed the LLM output showed superior consistency and readability compared to the manual therapist documentation, which is not sort of surprising. And this is basically how they did this. Basically, they had this order, they submitted to the Llama model, the larger Llama model, and then you've got an initial evaluation. If that was not good, of course, it continued iteratively, modifying the prompt until they got something good, which the therapist was happy with. And that worked quite well. This is published in the Journal of Applied Clinical Medical Physics. This is interesting, sort of slightly different idea of linking workflows, full workflow in this is plan Q type systems. So they want to completely have this within this vendor neutral AI platform called Plan Q. They developed and clinically implemented a full workflow for orchestration in a large multi-LINAC linear accelerator department, where it integrated multimodal data, LLM for linking sparse events into longitudinal patient journeys, operations research-based scheduling all this stuff, deployed it across 30 linear accelerators with real-time data curation and human feedback loops for data integrity. And what they found here, quite positively, 70% reduction in treatment planning, 10% decrease in individual planner workload, and about apparently an hour a day saved on plan checks. So obviously that's a good thing, which is worth looking further into. And what do I have now? Now it comes to medical education. In training exams, this is about the texted, the ACR radiation oncology and training examination, where they compare, they try to see how GPT-4 does on their RedOnc texted exam and using the red journal gray zone cases. I had no clue what those are, but I think I understand what they are. They're tough cases, which are more complex and difficult. And they used 300 questions from the texted exam through 5 API runs and 15 gray zone cases rated by senior radiation oncologists. Basically, you found these nice numbers. Basically, first of all, GPT-4 did better than 3.5. Duh, that's pretty obvious. They're very good for stats, for CNS, physics. Interestingly, for not sure why so poor, weak in brachytherapy, sort of average in dosimetry and the trials. And they did pretty nicely on those gray zone cases with very limited hallucinations and quite comprehensive and correct answers. So again, very promising data considering that all this is like 1 year old. I was wrong. This is 2023. That's when they were doing all these studies on medical examinations. Here, looking again for clinical competency using the scenario, radiotherapy scenario interpretation, 12 clinical vignettes across different diseases, 180 questions in all the domains of radiotherapy, used GPT-4 outputs, and they try to see how well they did. And basically they found that yes, they did reasonably well. You can see again, concise answer, reasonably complete, reasonably correct answers in some areas more than in others. Interestingly, weakest was in struggled with contours, dose fractionation, and individualization. Also underperformed a bit in clinical management. And the problem was that the errors were confident, but omitted key constraints or misinterpreted some of the borderline indications. So again, promising, even if not quite there yet. So that's that. Generally looking at the whole picture, across multiple studies, we have the expected predictable limitations, problems with hallucinations, problems in general with bias, which was not really assessed very much in these studies. We continue to stay, of course, with lack of explainability. We don't know really how these models perform. There's always a black box problem there. And with that, there's also the problem of domain drift, the fact that things can change, patients change, models have to change with them, otherwise it's not going to work well. And there's always in the back this ghost of medical legal risks anytime when you don't supervise very carefully with a human in the loop. Therefore, all these papers and sort of behind or big picture stuff that I felt myself is the same thing in other specialties like mine, is that the implementation framework for LLMs in healthcare, it's definitely here to stay. And the model has to be a human in the loop model. How much of a human in the loop, that depends on each specialty, of course. But that way, the LLM provides a sort of quick first opinion or second opinion, can check consistency, document support, but clinicians retain the decision authority. It's not going to be a full machine anytime soon. With the near-term recommendations, these are suitable for clinical decision systems, for this documentation automation, but again, not autonomous yet, and prospective validation and especially fine-tuning is required before routine deployment. I'm not even sure if specialty fine-tuning will be required. What's required is always prospective external validation for this data. Before I finish, a little bit about what we do in our lab. These are lower level stuff. It's not quite the fancy stuff that gets published in Nature. A lot of our studies are just starting as we go. You're not going to see any manuscripts yet. We're going to see just some diagrams of what we do. And you can see that there's like 5 different areas in which our lab is involved with. Some of these Martin knows very well because we're involved together. But we've got, for example, clinical documentation enhancement, where we work on summaries from the electronic health record. This actually happens to be in palliative care and oncology, not in pediatrics. We take the clinical notes, of course. We use these models, and then we evaluate the output in terms of summaries. And if those are good, then our clinicians can use the summaries and therefore save time face-to-face with the patient. To do this, it's quite a process. It's a PhD level full work that includes also comparing the process here, the validation workshop, where we compare AI-generated summaries with human-authored summaries using expert physicians to tell us how that works. And also how this is going to be used in real life. We actually use focus groups so that patients are involved from the beginning in our study with their opinion patients as partners in research. So that's one project. In the area of communication with patients, it's funny, I didn't even, maybe I will put, yes. No, I actually didn't put our main app because that doesn't have much AI. But here's an app that we're just starting on, really exciting. This is called POP. This is one of the startups where basically these are AI-based platform for patients that recover after surgery. But it's day surgery, so they go home and they got all these documents and papers from their doctor, but they have no idea what to do because there's all these things and they don't know what to do on any given day because there's so much. So basically what happens is that the AI captures, the patient basically captures all their documentation with photos and it puts it into the app, and then the app summarizes it and puts it in a format in any language that the patient understands what to do at any given point in time. It organizes all this information, and then it says, time to move. It puts you constantly, it gives you reminders when you have to do something or something else. I'm quite excited actually about this app. I hope that, I think it's going to work. It's going to be a lot of fun. Now I need to see if, where do I go back to my thing? Oops, just one second. I don't see my own talk. Sorry for that. That's, of course, I was preparing for this. Sorry for this. I've literally lost on my thing. I've lost the shared. I'm just gonna, for 1 second, I'm just gonna reshare it and move on. No, I'm sorry. It's still here. It has to be here. So where do I? My goodness. It really messed me up, as it always does. Oh, wait, it has to be here. Yeah, it's here. Good. You can see it? Sorry, I just lost my tab. Now I know. We also use it for reinventing patient-reported outcomes, and this whole big thing in clinical medicine across all specialties is focusing on patient-reported outcomes, and we want to sort of rethink about these from the perspective of using AI. In other words, rather than patients completing form after form after form, check. What we do is, first of all, we have two approaches. One is to extract these prompts directly using text-based mining with AI, with large language models from clinical note. But the other one, even more exciting one, is what we call narrative prompts. The patient just says for 10 seconds or 20 seconds how they're feeling in various areas that we're interested in. And then the AI takes the audio and, of course, with a secure on-site LLM, extracts the patient-reported outcomes, validated, compared to the standard, and then we can get basically some really cool methods to follow our patients with very little money involved in the process. Or very little patient time in the process. That's a major one we do. We also have another one. I'm going to need to be careful here because I'm going to go out of here. But this is for education, for medical education, and it's simulation. And simulation is used a lot in clinical medicine, as you know, for training, of course. What we do here with TIA is that basically TIA combines, it's a hybrid OSCE sort of objective structured clinical examination simulation platform. It uses virtual reality as well as an AI type mode, so that it's immersive, and every student at home, they can practice with different patients who are generated on the spot. This has already been done with AI. We're adding the VR in one single method. So that's how that is done. And finally, for research processes, this is interesting. We do several things for that, but the one that we're actually studying currently, and we've already sent us the abstract, is that we're using it for systematic reviews. And here is one sort of the early example. We already humans had done these systematics reviews, SR1, SR2 were two methods. We used, again, a sort of a free open access model, AI model, GPT-OSS, 20 billion. And we wanted to see if the AI can actually cut down the time that students had to spend screening 5,000 or 10,000 abstracts. And when we did that, we actually got some beautiful, very good results. You can see how both the sensitivity and the specificity is very good. And this is at the abstract stage. So it's not a problem as long as it's sensitive enough. Of course, you want it to be not so specific because you're going to go then afterwards, and it can help already the student. And currently in our lab, we don't do two students doing a systematic review together. We actually do one student plus the AI, and that's worked very, very nicely. So that's that. And I think that right now it's basically just quick learnings from this whole thing, from our own learnings. LLM works very well for narrow, low judgment tasks. I'm nowhere close to using it. I don't believe it should be used yet for full clinical decision making. They definitely can handle, we like the idea of local LLMs, not cloud-based, so that the RABs are happy and we can efficiently handle privacy-sensitive, anonymity-preserving tasks. They definitely accelerate significantly our so-called research plumbing tasks, like the boring research tasks, but they need to be very carefully reviewed every time. They help us a lot when we use them for scientific writing. All my students know, I'm very sensitive to GPT style of statements and bullshit, basically. And we're very careful about that. And every output needs to be humanly reviewed for errors and to make sure that it is indeed what our intent is. And therefore, LLMs for us remain totally technology in the service of clinical problems with a human in the loop, essentially in all stages. So in general, from today, key takeaways. The LLM transformer architecture is very well suited for clinical applications, especially in multimodal formats with text and image, as well as context comprehension. For clinical imaging, it's already been shown to be quite accurate and definitely improves productivity. That's something to always consider. All multimodal models work better than single modalities. We know this, and that's definitely the case, and that's where we can use LLMs nicely for. There's still problems of explainability and, of course, hallucinations. They're always there. That's where the human oversight comes in. Performance varies significantly across clinical domains. We're finding more and more that for some questions, it's great, for others it's not, and that's okay. That's how it is when you hire your postdoc. They're going to be good in one area and not in another. So that's just how life is. And we do encourage local deployment as much as possible to maintain accuracy still on very sensitive, data-sensitive extraction tasks. And that's it. That was my talk.
Thank you very much, Dan. Thank you very much for this great talk, honestly. It was great. Thank you for the specific efforts you've made towards medical physics, and that's very much appreciated. No, thanks a lot. Sure, there are questions. I'll start with questions here in the room. If someone has a question here in the room or online. Online, please speak up. I don't see the participants. Oh, yes, I do.
I could ask a question.
Yes, thank you, Pete.
Sure. So, sorry, my son's in the back. Thanks for the talk. Yeah, I think I'm not as confident as you are, perhaps in the near reduction of hallucinations. I still find GPT-5 saying things that I know are wrong. So I guess the question is, what do you think needs to be done or to establish that level of trust where we can say, okay, I'm going to use a Gen AI GPT, and whatever it gives me, I no longer need to validate it or verify it, because I personally am not at that point, and I've seen examples where it's not there. You seem a little bit more confident, so maybe you can tell me about how you came to that point.
Sure. No, and in fact, I'm probably a lot closer to you than you think, Peter, because first of all, yeah, I've stayed away from GPT, and I use Perplexity, which I've from the beginning was set on good documentation of references, so that every search I do, even when I ask about my carpentry, it gives me references which I click on to see that it is correct. And the level of hallucination on the references has dropped considerably to, I would say, something in the 5%, which makes me much more confident with that. But the reality is that, no, I don't trust it 100%. I've never submitted or worked with any output from GPT without reading it and passing it through my own thing. Now, do I pass it through another iteration or through a book or textbook or something like that? No, I don't do that, because I've got the references and I just make sure that the references are good. So I find myself, over the last year, I've used extensively. We use it. I mean, I use it, probably like 50 times a day in my workflow, which is research plus clinical. And I'm very happy with it, at least with good models. For people that don't use Perplexity, I encourage everybody to veer towards Claude. Claude has been consistently better for scientists than GPT has, and ChatGPT has. And now it just came out with Claude Coworker, which is unbelievable. It's basically reliable agentic stuff. But that's the other point, is that I don't trust agentic stuff, an agent that goes through 5 steps and then gives me the output, because you have to have a much higher trust level if you trust it with 5 steps without going into the loop, than if you trust it with 1 step that you can check it. It's basically what the dense supervision of machine learning layers was all about. This is what I'm doing with agents. I want to know, I'm good with an agent. I like to, at every step in the agentic workflow, I want it to see that it's doing okay before it scales up, because otherwise it can perpetuate some horrendous stuff. And yet it seems that out there in the world, I mean, for example, for coding purposes, Claude is this newest advance. They've brought this full co-worker, which they sell at $200 a month. That replaces your postdoc and a student and so forth, or a coworker, was fully created with AI coding.
Okay, thank you. Yeah, it does sound like we're more on the same page. I got the impression you were a little bit more taking it as a can, but yeah, I think you're right in your assessment that when you have references and you can check things, you're finding that the hallucinations are less, but you still always have to do that due diligence.
Due diligence is the right word, is the right term.
Super, thank you.
Thanks, Pete. I believe, Eugene, you may have a question.
Yep. Yeah, I have a question. Thank you very much, Dan, for your talk. I'm a PhD student at the MPU here. So I agree with you that the LM is very good at doing, more of the basic, more mundane stuff that people don't want to do. So we actually recently conducted a study where we do more of a clinician AI collaboration, where we ask the clinician to evaluate the LLM outputs so that it can gain more trust in that way. So I wanted to ask you more of your opinion on for example, the translation towards clinical decision support as a clinical decision support tool. So I agree with you that currently, we don't really quite see that happening yet, regarding clinical reasoning side of things. But I wonder, what is your take on how it can actually be used in the clinic, or how it can, what do you think are the steps that needs to be taken for us to get there as a clinician's point of view?
Well, the issue with in clinical decision support is very well captured in the book AI Snake Oil, and that is the complexity of the system. When a physician, myself as a surgeon, when I decide that a child that I'm treating has something, or one diagnosis or another, it's not just about doing Googling the conditions or knowing the conditions and going in a textbook and finding out with all that information, check. This is what the clinician has. There's so much more that goes in context of the patient, where they come from, their level of the confidence of the patient themselves, that they have certain symptoms or not, the way that we interpret some symptoms and signs as being soft and others hard. In other words, the patient says that they're feeling unwell. That's a soft sign. How do you deal in the AI with unwell? Like, what do you do with unwell? It's not like temperature equal 38.5, right? It's not that. And even that, patient may say, oh, my child had fever at 38.5. Yeah, wait, but I don't trust that you took it properly, and so forth. So all these things play an account, and that's why clinical decision support, for me, when you say CDP, clinical decision support, I use it every day. The way I use it is that I see the patient, I see what the diagnosis, what the problem is. I say, I'm not sure about this one after 35 years of practice. I run my Perplexity. Perplexity gives me immediately a few diagnoses, and I have them now in my head when I go to see the patient. And then when it turns out to be this rare diagnosis that I agree with, this is what it is, and I forgot all these years of practice how to treat it, I just get the latest treatment in this. To me, that's clinical decision support, even if that's not what AI scientists would like to do, whereas this Dr. AI that does it for you. I think we're very far from there, and I actually don't think that it's necessary to have that, because the interpersonal, emotional, psychological trust relationship is so essential in clinical medicine that I don't see any risk from doctors losing their jobs. But the way we said for already, I said this for, I think, 3-4 years already, that AI will not replace doctors, but doctors with AI will replace doctors without AI.
Okay, thank you.
Thank you so much, Dan. It's so interesting. We could discuss about that for a long time. Unfortunately, we're past the hour.
Yeah.
But let's thank Dan once again.
My pleasure. Thanks. It was a pleasure having you. I wish I could have been there to actually interact with you, but it's what it is. I've got clinic every Friday.
That's totally fine. Thanks for showing
Super.
up online. Thank you
My
very much.
pleasure. Take care. Bye, everyone.